Hello everyone, welcome and thank you for joining us for today's webinar titled Assessing and Supporting Reproductive Healthcare Needs and Desires of People Living with HIV. My name is Sarah Semelka. I'll be moderating the webinar today. Our program today is co-sponsored by the Midwest HIV Prevention and Pregnancy Planning Initiative, which is a project of the AIDS Foundation of Chicago, along with the Midwest AIDS Training and Education Center. Before I introduce our first speaker, I just have a few short housekeeping announcements. Just so you know, all attendees are in listen-only mode, and we won't be taking questions over the phone today. However, anyone and everyone can submit questions at any time using the chat feature. During the Q&A segments, I will read selected questions that have been submitted. And those will be more of a clarifying questions, and you can see here a screenshot of how to submit the questions. I'll save discussion questions for the end, where we can open it up to all of our panelists and we can have a discussion about any of the questions that come in. You can also email me questions at the address that's on this slide, ssemelka@aidschicago.org. This webinar is being recorded, and we will make the recording available to all registrants. And then finally, for those participating live today on September 26th, there is the opportunity to receive CNE-CME credit, 1.5 hours. To be eligible, you need to be logged into the webinar system for the duration of this webinar, which is scheduled to last 90 minutes. And in addition, you'll need to fill out the evaluation. The webinar system will send you a SurveyMonkey link following this webinar, and you'll need to fill that out before receiving credit. All right, so now I'm going to turn things over to Pamela from the MHPPPI project to begin our presentation.
Greetings, everyone. My name is Pamela Tassin. I'd like to first state that Maggie, Castor, my co-facilitator, and I have nothing to disclose today. So the Midwest HIV Prevention and Pregnancy Planning Initiative aims to improve the reproductive health care of people living with and vulnerable to HIV. To achieve this goal, we've been training clinicians throughout the Midwest on the latest in HIV prevention options, including pre-exposure prophylaxis, and also meeting and affirming the pregnancy desires of people living with HIV. The AIDS Foundation of Chicago launched this project with funding from the U.S. Department of Health and Human Services National Prevention Partnership Award through the Office of the Assistant Secretary of Health. So our learning objectives for today include employing new strategies to meet the reproductive health care needs and desires of people living with HIV, initiating affirming conversations with women living with HIV about their fertility desires as well as that of their partners, supporting safer conception for sero-different couples, and also facilitating access to contraception and conception care, the resources, support, and also assistance for women living with HIV. So taking a look at U.S. cis-women and HIV, 75% of people living with HIV in the U.S. are of reproductive age, which includes 15 to 44, and more than 140,000 male-female sero-different couples exist here in the U.S. Now, while there's been a decrease in new infections among African American women, they still continue to represent a disproportionate 64% of new cases among all women. Many factors contribute to risk and vulnerability for HIV, including unprotected anal sex. It's estimated that 40% of HIV infections among U.S. women with multiple risk factors are actually linked to unprotected anal sex. Opportunities have been missed and continue to be missed for provider-initiated conversations with people living with HIV about sexual health, HIV, and pregnancy planning. Basically, providers are not talking with people living with HIV about their sexual health and pregnancy planning, and so we're hoping that will continue to change. So looking at reproductive rights, we have a statement here from the World Health Organization regarding this. And so the way that they outline this is that the basic right of all couples and individuals to decide freely and responsibly the number, spacing, and timing of their children, and to have the information and the means to do so, and also the right to attain the highest standard of sexual and reproductive health. And this is what we support, and this is what we're about. And so this is really the baseline premise for our time here today. So looking at people living with HIV and their reproductive health needs and desires, reproductive health care is important for all people regardless of their HIV status. For people living with HIV, high-quality reproductive health care optimizes health outcomes by increasing treatment and prevention of STIs, enabling safer conception strategies, and also demonstrating the recognition and respect for people living with HIV as sexual beings. People living with HIV have shared through surveys, individual interviews, and also focus groups that they want and need things such as sexual reproductive health services and support directly from their providers. And so they've been conveying this. And so we've really wanted to share this information with all of our clinicians to know these things. And so some of the things that are included: access to a full complement of high-quality sexual and reproductive health care services across their lifespan, not just for the young, including and beyond childbearing years. And so we're talking about from the very beginning to the very end. We also know that there's a need for building and sustaining healthy families, planning pregnancies and spacing their children, knowing about and accessing all available prevention options such as pre-exposure prophylaxis or PrEP, post-exposure prophylaxis or PEP, treatment, and also female condoms. People living with HIV also cite that provider-initiated conversations with their clinicians about their sexual experiences, practices, and fertility possibilities is key. Discussion of sexual experiences is particularly important as it can help to create the space to discuss past and possibly current traumas. We know that women living with HIV experience high rates of sexual trauma, and asking whether sexual experiences have been consensual or non-consensual can foster a more open dialogue in allowing clinicians to better meet the needs of their patients. So taking a look at clinical guidelines on people living with HIV and fertility, there's a combination of federal and global health authorities, as well as professional health care associations that have released guidelines, recommendations, and opinions stating clearly that people living with HIV should be offered comprehensive reproductive health care services, including preconception care and PrEP. You can refer to CDC's expert panel on the prevention of mother-to-child transmission and other guidance and recommendations about which safer conception strategies can and should be used, when and with whom. But we also know that people living with HIV are not getting the health care that they need and want. And there's a number of reasons for this, and we're going to dive into that now. So looking at reproductive health care barriers for people living with HIV, we've got these three areas here: stigma and biases, structural barriers, and also inadequate provider-patient communication. So both internal and external stigma, preconceptions, and biases pose significant barriers to accessing high-quality care. Stigma really enables a number of structural barriers, such as discriminatory policies, and it also impacts communication between providers and patients. Any of these factors on its own is significant, but they do not stand alone. Instead, they reinforce each other. While these issues are challenging, they are not insurmountable. They can be disrupted to improve the care for your patient. Eradicating poverty and overturning discriminatory laws requires significant work. But as we will talk about this today, providers can take deliberate steps to effectively minimize two of these factors: stigma and biases, and also provider-patient communication. So taking a look at stigma against women living with HIV, There was a study that was done by AMFAR in 2008, and it really provides a powerful and concerning picture of the American public's view of women living with HIV and their desire and decision to have children. As you can see from this slide, there's no other condition inquired about that received as low of an approval as HIV did. These findings clearly and plainly speak to the stigma faced by women living with HIV who desire children. And just a quick view here on the slide, you see there at the top, women living with HIV or those that are HIV positive. Then we see cancer, depression, multiple sclerosis, hepatitis C, Down syndrome, and schizophrenia. And all of those other conditions received higher approval ratings from both males and females identified as male-female in these surveys. And you see that a person living with HIV received the lowest approval ratings. So this is very concerning and really reflects the issue of stigma for people living with HIV. And so Steiner talks about stigma and how it appears to be one important factor contributing to these missed opportunities that we're speaking of today to strategically and safely plan pregnancies with patients, and then thus preventing the full application of all the science and knowledge available to prevent new infections while maximizing autonomy and respect for human rights. So looking at structural barriers to sexual and reproductive health care for people living with HIV, we have three areas, excuse me, social cultural norms, economics, and policies. So looking at social cultural norms, oftentimes there are assumptions about who wants and should have children. Often men are not considered when it comes to assessing and considering reproductive desires, and also a lot of times men are not engaged in conception conversations or care. We also have economics. The majority of people living with HIV are known to be at or below the poverty line. The AIDS Drug Assistance Program formularies exclude contraception, and there's no Medicaid expansion in approximately 19 states, which includes Wisconsin and Missouri, which is troublesome. And we know that currently we continue to have our challenges around health care and healthcare policies and access. And speaking of policies, sexual reproductive health has been attacked and continues to be attacked at both the state and federal levels. We currently have HIV criminalization laws in 34 states and 2 territories, as well as the federal government. 18% of women living with HIV reported being asked to sign a document about HIV criminalization laws related to non-disclosure, transmission, and/or pregnancy. So we know that critical conversations are in fact lacking. The Positive Women's Network found that there are fewer conversations than we might believe between women living with HIV and their providers. So while some conversations are occurring, they're most often initiated by the woman or by the patient, not by the provider, and there's a difference here. So one study found that age was the biggest indicator of whether conversations are actually occurring. Women 30 and under were engaged in conversations about reproductive desires 6 times more than women over 30. Regarding men, it seems rare that men of any HIV status are asked about whether they would like to have children and how a provider could support them in building a family should they desire one. There's a number of factors that result in barriers to effective communication between providers and patients. Understanding the complex factors that influence what and how patients and providers discuss relevant issues can help us to better meet patient needs. And so we see here on this slide that there's barriers that are more specific to patients and barriers that are more specific to providers. And so we have patients that may feel a distrust or have a distrust of the healthcare system. They may have had negative experiences with their medical community or the medical community. They may have a history of trauma. Estimates among women living with HIV, for example, intimate partner violence, there's 55% that share that they've experienced that, and then post-traumatic stress disorder at 30%. In addition, feelings of judgment and stigma. Looking at this from the perspective of providers, challenges include having limited time with patients, limited sexual reproductive health knowledge, discomfort managing contraception, lack of violence and trauma inquiry experience and training, believing that condoms are sufficient for HIV prevention, feeling that topics are outside of their scope, assuming that another provider must be discussing and addressing sexual reproductive health issues, and then also them making assumptions about sexual behavior of their patients. So why do provider-initiated conversations matter? Provider-initiated conversations are really critical to meeting the sexual and reproductive health needs of people living with HIV. These conversations establish an open and safe space for patients to be honest about their lives and their desires. It also enables providers to offer more patient-centered care. Having a provider start the dialogue with their patient about their sexual lives and desires just demonstrates that the provider really wants to understand the patient's needs and concerns around everything from sexual pleasure to risk reduction to family planning. Informing patients of the many options that they have for HIV prevention, safer conception, and contraception can really help to reduce an individual's anxiety, fear, and stigma that may accompany sex. The failure to start conversations with people living with HIV around their reproductive needs and desires can be as disapproval of their childbearing desires, and it can be conveyed in that way as disapproval. And it's really important for providers to recognize that even if a conversation isn't had, patients may still decide to move forward with conception without the guidance and support of a provider, which is what they really should and desire to have. Such attempts could increase the risk to all parties involved, both including the individual, the partner, and also the fetus. So the literature indicates that many women living with HIV are unaware that with provider guidance and care that they can in fact deliver an HIV-negative baby, and that they can do this with reduced risk to themselves and their partner. So learning that safer conception is possible can be a positive and life-changing experience for many individuals and couples. So we're going to take a look now at assessing and supporting reproductive desires. Preconception health care is not just for women who are planning pregnancy. It's relevant to anyone of reproductive age, including people that are living with HIV. Preconception health care supports health in the event of pregnancy, whether it's planned or unplanned. It helps to reduce unintended pregnancies and really helps to also promote awareness, responsibility, and active partner participation, which is really the most desired outcome, and also results in better health outcomes for parents and their babies. So some topics of preconception counseling for people living with HIV should include HIV disclosure, knowing the status of the partner and testing, as well as identifying the readiness for conception and for having children, as well as their contraception options if that's what's desired. Also, their current treatment regimen, the risks and benefits of HIV drugs. Conversations also need to include viral load levels and medication adherence. Also, the HIV impact on pregnancy and the pregnancy impact on HIV. Perinatal and partner transmission prevention strategies, as well as spacing of pregnancies. So MHPPPI likes to use a strategy which is called the one key question. And so some of you are probably very familiar with the one key question strategy. And so, asking about fertility desires is, of course, an important component of HIV prevention. Providers should ask all people and again, I want to reiterate all people, regardless of their HIV status or gender identification, if they want to have children in the next year. These are not one-off conversations, but should be asked at every visit as people's desires and life situations change. Be sure not to assume that a patient's reproductive desires are based upon how the person presents, female, male, transgender. Supports are available for individuals and couples seeking to have children. By asking this one question, you can help to facilitate making these connections. So you can start a dialogue about several sexual health issues with one key question. Do you want to have a baby in the next year? It's not just a yes or no question. This question can be particularly powerful for people living with HIV who may not know that delivering a healthy baby is possible. This helps to open up the dialogue about the many ways in which people living with HIV can substantially reduce the risk for themselves, their partners, and their new baby. It also opens up those conversations about safer conception strategies, the HIV status of the partner, as well as current sexual practices. Also preconception care, contraception needs and options, as well as adoption and surrogacy. So talking with patients who don't desire pregnancy, it's important to identify and explain that pregnancy risk is 85% over a year when no contraception is used, and so helping them to understand the risk around not using contraception, and I say risk for an unplanned pregnancy, informing them of the variety of methods that are in fact available, offering guidance that reflects data available on antiretrovirals and contraception drug interactions, remembering that fertility desires change with relationships and situations, and also knowing that no right now does not mean no, not ever, and being clear on that. Talking with patients who are unsure, for people living with HIV, identifying their knowledge base or the concerns. There may be a reason why they're not sure right now. Helping to sit down and discuss with them safer conception strategies, and also using follow-up questions. For example, do you know that people living with HIV can have HIV-negative healthy babies? Do you intend or want to have children in the future? Do you feel that now is not the right time to become pregnant? Do you have the resources that you need? And then also, what resources do you need, and do you need help accessing them? So those are some really good discussion questions to help to learn more on how clinicians can support their patients. And then talking with patients that are actually considering pregnancy. People living with HIV can have healthy HIV-negative babies when they're in care, when they're following proper medical plans. Pregnancy planning is the first step in decreasing perinatal transmission. Education is key. You want to make sure that there's an opportunity to continuously reduce anxiety through information, support, and resources, and then also discussing safer conception strategies. So at this time, I want to turn things over to Maggie, my co-facilitator, who's going to talk about preconception healthcare services and beyond.
Hello, everybody. Yes, we're going to dive right in. Thank you, Pamela. So on this next slide where it says preconception healthcare services, this is a list of preconception care services from the CDC. It's important to note here that conversations about preconception health should occur on an ongoing basis with both men and women that you see. So as Pamela alluded to earlier, we talk about it with our women and with our men when they want to conceive, if they feel like now is the right time or in the future. We want to have these ongoing conversations with them because as more than half of pregnancies in this country are unplanned, it's critical to include both preconception and contraception conversations into our primary care healthcare visits. So this isn't just for OBGYNs talking about birth control or starting on prenatal vitamins. We want to have these initial conversations to see the wants, needs, and desires of our clients. So the basic recommended actions are the same for people who are either desiring pregnancy, are okay with pregnancy occurring regardless of their HIV status. So each service is relevant for people of any gender. In addition to what's listed, preconception health actions include, counseling our patients to stop smoking, step are alcohol use, drug use. Men should also decrease the amount of alcohol use because it can affect their sperm count. We want to avoid certain over-the-counter medications with our women that would affect getting pregnant or when they are pregnant. In pregnancy care, we want to talk with a provider about the safety of the prescription medications, so going over the patient's med list and seeing if certain medications are safe to take during pregnancy. And I know later on we're going to talk about, if looking at their antiretroviral and seeing if it's compatible with pregnancy and switching them to something that is, in case that pregnancy were to happen, that their medication would be a safe regimen for them. We want to counsel our women to start taking folic acid or a prenatal vitamin. We want to talk about having a healthy diet, exercising, and as well as keeping their immunizations up to date. Overall health care, healthy person visit, normal annual exam can be done with this. Next slide. So here is the preconception counseling and care algorithm for people living with HIV. This is available at MHPPPI.org, and it's a great just little counseling tool that we can keep in our pocket or at our desk side if you want to laminate it. I know a lot of groups just keep it on the side of their desk because they don't use it every day, but it is a really, really great tool to have. Next slide. So in addition to the recommendations for people of any HIV status seeking to become pregnant, there are a number of different steps that must be taken to support women living with HIV who do want to become pregnant. First, we want to really check their viral load, because if they don't have an undetectable viral load, we want to talk to them about delaying becoming pregnant until their HIV is under control, so they are virally suppressed. We want to also look at the CD4 count, because if a woman has a CD4 count of less than 50, then they may not actually be able to become pregnant because they're so immunosuppressed. So we want to build up those CD4 cells, continue taking our antiretrovirals, and talk about delaying pregnancy until we're virally suppressed and our CD4 count has rose. To enable the best outcomes for both mom and baby, we want to work with them to achieve this level. So talking about them about starting a prenatal, continuing their antiretrovirals, healthy diet, exercise, and things like that. We want to determine if their current antiretroviral treatment regimen is safe during pregnancy, and if the medication may need to be changed to one with appropriate safety profile, so that it has at least one drug that does cross the placenta. I know a lot of people in the old HIV practice that I used to work in would change women of, baby-bearing age to medications that were safe in pregnancy, just in case the woman were to get pregnant, that it would be safe in pregnancy. And I know that there's been some new guidelines that have come out that says, there are a lot of regimens that are safe, HIV regimens that are safe to take in pregnancy, and the recommendation is just to continue that therapy as long as they are virally suppressed. So it would be really important to look up the guidelines if you had a woman in that situation. But we also want to be sure to evaluate and manage any side effects that she may be having as a result of her treatment regimen. We don't want them to just stop taking their antiretrovirals. If they're having nausea, we can give them Zofran and so forth and so on. It's important to make sure that the side effects such as hyperglycemia, anemia, hepatotoxicity, because these can all negatively impact maternal and fetal health outcomes. We want to effectively manage these as well. Next slide. So preparing for a healthy pregnancy involves assessing the readiness of the partner as well. So like Pamela alluded to earlier, talking about the men to see when they want to conceive or if they have any desires and things like that. So it's definitely important to talk to both the woman and the man. This involves talking with the partner about the preconception plan as well as screening them for HIV if their HIV status is unknown, as well as testing and treating them for any STIs, as that can negatively impact the pregnancy. If a male partner is HIV positive, it's important that he is also virally suppressed. Because antiretroviral treatment may be associated with a higher prevalence of semen abnormalities, such as low sperm count, low motility, and a higher rate of abnormal forms, and low semen volume, it's recommended that a semen analysis is also conducted for men. Now, in my practice, I usually have them try for a couple months to see if they can conceive on their own, but sperm analysis is a very inexpensive test that we can order. Next slide. So having a negative family can be the most positive thing in a person's life. And with the use of safer conception strategies, such as treatment as prevention, which is the TASP, or PrEP-Ception, and other strategies, this can happen for people living with HIV and their partners. So above is a picture of Andrew Pulsiver from Phoenix, Arizona, who has been HIV positive since birth. His parents died from AIDS. However, he was the only one of his siblings to be diagnosed with the illness. Andrew and his wife, Victoria, conceived their first child using fertility treatments, but conceived their second and third children naturally. The 33-year-old's viral load is classified as being undetectable. So just recently, going along with this, the CDC has further clarified the previous conception guidance that was put out. So the new guidance was issued and quotes data from HIV trials showing that treatment alone can prevent HIV transmission when couples with mixed HIV status desire to have a baby. It then goes on to list other methods for safety conceiving a child when a man is living with HIV and a woman is not, which they include pre-exposure prophylaxis or PrEP, limiting condomless sex to ovulation, and sperm washing with technological support. Importantly, unlike the June guidance, it does not imply that physicians must counsel patients to use all methods together to prevent transmission. And this updated guidance was published on the 17th of August, so it is a fairly recent update for clarification purposes. Next slide. We know that viral suppression is important for both the person living with HIV's health and for reducing transmission. We know that taking HIV medications for prevention is a safe and effective way to reduce onward transmission of HIV and opens up new possibilities for family building for people living with HIV and serodiscordant couples. So these new prevention options play a critical role in helping HIV-impacted couples achieve their reproductive desires. So there was the HPTN study in 2011 that found a 96% reduction in HIV transmission among heterosexual couples compared to those not on antiretroviral therapy. A partner study in 2014, which included straight and gay men and other MSN, where they found that no HIV was transmitted if the person had a viral load below 200. And I just want to mention again, there was no HIV transmission if the person had a viral load below 200. So treatment as prevention does work. Next slide. Why is the use of PrEP important for pregnancy? Well, let's talk about it. First, it's important to note that a woman's HIV susceptibility is higher during her pregnancy. Perinatal transmission is higher when HIV is acquired during pregnancy or lactation. So there's clinical studies that show that acute, newly acquired HIV infection puts both the mom and baby at an even greater risk than a woman living with chronic HIV, even if the chronic HIV is untreated. There was up to a 15-fold increase in perinatal transmission compared to a 4-fold increase in lactational transmission. And so basically what the experts are recommending is that PrEP should be offered during pregnancy and lactation. The benefits and risks should be discussed with the patient, and we need to talk about how PrEP has a reassuring safety profile in pregnancy and lactation to help these women understand how great of a resource that PrEP can be. We also want to be vigilant to prevent transmission during breastfeeding. So like I said, when a woman delivers, we want to counsel them about how important PrEP is and the side effects and the benefits of taking PrEP during lactation and not just stopping after delivery. But we also want to have a shared partner decision making with the client. So we want to assess her wishes and needs as well. Next slide. For the women looking to conceive, we want to start daily doses of PrEP. We want to do a daily oral dose 1 month before conception attempt. And we want to, so it's really important at this point that we're talking about preconception counseling with these ladies so we know when and when to start the PrEP before then, or else if we're not talking to them about when they would like to get pregnant, then we would have no clue or conversation to have with them about when we can start PrEP for conception. We want to continue this daily oral dose until 1 month after the last conception attempt. Or we can talk about in the next slide how we want to continue onwards throughout the whole pregnancy, depending on the wishes and desires of the patient. So we'll go to that next slide where it's talking about expert recommendations, where we offer it during pregnancy and lactation. So if a woman just wants PrEP for that conception attempt, we can start them, like in the previous slide, it said 1 month before to 1 month after the conception, or if their risk is continued, we want to talk to them about the benefits of staying on the PrEP throughout whole pregnancy and lactation. Next slide. So we want to talk about the following with the couples. We want to talk about the potential risks versus benefits. So we talk about, common side effects of Truvada. The most common one I saw in practice was nausea, watching kidney function, but we also want to counsel the patient on the benefit while incorporating the patient's wishes. So the benefits of staying on PrEP, and, some patients say, I just want to stay on it so I don't have to worry about anything, and, talking to the patient about their wishes and needs. We want to also continue to have them use condoms after conception to reduce STI and HIV risk. So PrEP does not prevent against STIs, so it's really important to continue using condoms. We want to teach them about the signs of acute HIV infection. So we say, have there ever been a time where you felt like you just had the flu? Flu-like symptoms, fever, chills, achy. We want to talk to them if they do develop any of these symptoms, that we want to get an HIV test as soon as possible, because if it was positive in pregnancy, there's a large risk for babies to be affected. So we would want to start antiretroviral therapy as soon as possible. And we want to continue to talk to them about the pros and cons of staying on PrEP after conception for lactation purposes. Next slide. So preventing perinatal transmission, most babies who contract HIV do so during the labor and delivery process. Providers should discuss the labor plan with their patients. It's important that the woman brings her HIV drugs with her to the hospital, particularly if they end up delivering in a hospital where they're not registered. So there's some, small, quaint, small town hospitals who sometimes don't have the antiretrovirals in their pharmacy and would have to send off for them. So it's really important to counsel our women to bring their ARVs to the hospital when they are supposed to deliver, just in case anything were to happen, they can stay on these throughout their whole time in the hospital. Next slide. So let's talk about vertical transmission. So vertical transmission of HIV is less than 1%, providing that the expectant mom is receiving care by an appropriate medical team, including an OB for prenatal care and an HIV specialist. And then as needed, we can bring in mental health and drug abuse treatment services as well. So we want the mom to adhere to her her antiretrovirals, and make sure that she has an undetectable load by delivery, preferably as early in pregnancy as possible. When infection does occur, it's generally in the labor and delivery process or peripartum, as we mentioned before. So in utero, the placenta provides protection. HIV molecules are too large to cross the placental barrier, so this offers protection from infection. But during labor and delivery, your bag of water or your membranes rupture, and this acts as the defense against bacterial infections for the baby. So when membranes rupture, that defense is gone and baby can be exposed. So studies indicate that the risk of a baby becoming infected increase as the length of time the membranes have been ruptured and with each vaginal exam. So think like when the obstetrician comes in and checks your cervix. The baby makes its way through the birth canal in an environment where blood and secretions carry HIV. So if the viral load is high and antiretroviral medication is not provided to mom and baby, then the risk of transmission is even greater. Breastfeeding further increases transmission an additional 8 to 16%. However, we don't know the transmission rates for women with an undetectable viral load, as that has not been studied. But just for clarification, the U.S. guidelines continue to recommend that women living with HIV do not breastfeed their babies. So there's wonderful resources like Women's Infant and Children, abbreviated WIC. They have great resources for mom to be able to get formula and things like that. So we prefer that women go ahead and bottle feed these babies. Next slide. So let's talk about antepartum transmission. While most perinatal transmission occurs at labor and delivery, infection can occur in the antepartum or transplacentally. So in utero, HIV transmission typically occurs when a woman contracts HIV during her pregnancy, as the viral load during acute infection is very high. Also, the women who are not taking their antiretroviral meds, if they have a high viral load or contract other STIs during pregnancy, are all at risk, increased risk for transmitting during antepartum. So infections can increase the transmission, especially with placenta abruption or chorionitis, which results in the inflammation or placental breakdown and allows the transplacental transfer of HIV to the fetus. So these are all reasons that a mom could benefit from receiving IV AZT during labor and delivery. However, the new guidelines state that you can forego interpartum AZT if the woman has a history of an undetectable viral load and is retained in care. So a lot of times when I was in the HIV practice before I transferred over to OBGYN full-time, I would talk to the OBs delivering women living with HIV patients, and they would say, you know, they've seen the updated guidelines, but a lot of times it's risk versus benefit when that viral load was drawn, because, you know, I know in our hospital we don't get viral loads back the same day. So a lot of the OB docs still do the interpartum AZT with labor, even if the woman has a viral load above 1,000. And I'm sorry, I made a mistake before, but IV AZT can be avoided if the viral load is less than 1,000, not undetectable. But if it's greater than 1,000, then they recommend IV AZT. But a lot of doctors, even if the viral load is less than 1,000, still continue to hang that IV AZT, as it does nothing but could help a woman. So next slide. We want to consult the clinical guidelines for considerations and the latest on recommendation regimens for pregnant women. We want to support her retention and care so that she can achieve an undetectable viral load. And then we want to follow the PACTG 076, which states that AZT is given to mom for 4 hours until the cord is clamped. And then we want to administer AZT to baby for 4 weeks. So high risk mothers in labor and delivery, if the woman is not adherent or has a known viral load, or her viral load is greater than 1,000 at the time of delivery, the woman should be scheduled to have a C-section at 38 weeks. And IV AZT should be continued to be administered to women living with HIV whose viral load is greater than 1,000, as I mentioned before. And baby should still receive triple therapy per the DHS guidelines. And then the woman should be counseled that not to breastfeed. Counseling should be provided to mom to prepare for questions due to cultural family practices. It's important to note the sociocultural issues regarding breastfeeding for many women. For some women living with HIV, the decision not to breastfeed raises concerns that others will know about their HIV status, that they will not enjoy as strong of a bond with their baby, or that their baby will not physically be well. So it's really important to counsel these moms during their pregnancy not to breastfeed, instead of, you know, putting this on them as soon as they deliver baby, because a lot of times you'll get a lot of pushback and concerns from mom. So I try and make it as a most positive thing that we can, you know, Unfortunately, there's a higher risk with you breastfeeding this baby, so we really want this baby to be bottle fed, and this is what the guidelines recommend. And if you have other children or a husband or a partner at home, then the partner can be more involved with the feeding, as you know, you have the bottle and the baby doesn't have to breastfeed. And just really talking up bottle feeding and how beneficial, and then helping with resources of formula and things like that, because a lot of women tend to get anxious about the monetary amount that comes with formula, pardon me. But it can also be psychologically difficult for women who see breastfeeding as an integral to their identity, as a mother. Providers can help allay some of these concerns and ensure the woman has the support that she needs to do bottle replacement feeding. We really want to support her as much as possible with this. Next slide. So the PROMISE study looked at African and Indian women living with HIV and HIV negative infants. So this was a multi-component study that aimed to determine how best to safely reduce the risk of HIV transmission from women living with HIV to their babies during pregnancy, delivery, and after childbirth, while preserving the health of both the mother and the child. So just to continue to say, the U.S. still continues to strongly recommend against breastfeeding by women living with HIV. Next slide. So there's low-risk mothers in labor and delivery where their viral load is less than 1,000. IV AZT is not required for these women, as long as they're continuing to take their antiretrovirals every day without any missed doses. And we want to make sure that we are checking a viral load late in pregnancy and not just going off of a viral load from early in pregnancy. So the low-risk moms would be considered those, like I said, who are taking a daily antiretroviral regimen and their viral load is less than 1,000. There's no concerns about any adherence or tolerance to their regimen. But like I said, many clinicians still do administer the IV AZT just as an extra check in labor and delivery. But the baby still does receive 4 weeks of AZT as suggested by the guidelines. Next slide. So for high-risk exposure to newborn, AZT is given for 6 weeks. This is combined with 3 doses of nevirapine, which happens at birth, 48 hours, and then 96 hours after the first dose. And this is begun as soon as possible. So some experts recommend triple antiretroviral prophylaxis for infants at higher risk of acquisition, as described above. But there's no data demonstrating improved efficacy for a 3-drug regimen over a 2-drug regimen in prevention of transmission. So for the low-risk mothers, how the AZT is given for 4 weeks to the infant, and then for high risk, it's given for 6 weeks. A lot of times the pediatricians will just tend to do the AZT for the total of 6 weeks, as there's no extra harm in those last 2 weeks for the low-risk babies. But if the membranes rupture in a woman who has a C-section scheduled due to the increased viral load of greater than 1,000, it's no longer certain that there's any benefit to perform the C-section, as exposure may have already occurred. So pregnant women with a high viral load need 3 hours of interpartum AZT regardless of vaginal delivery or C-sections. And babies born to moms at high risk may also receive the 3-drug antiretroviral regimen. Next slide. So natural childbirth is always recommended when it's an option, as C-section is a surgery, so it has higher risks of infection and recovery time. But research tells us that there's no increased benefit for a woman to have a C-section when her viral load is less than 1,000. So we really want to counsel mothers on the importance of taking their antiretrovirals and how they can still have a natural birth if their viral load is suppressed less than 1,000. Next slide. Pregnancy spacing is important for both maternal and child health. In addition to giving the body a chance to heal, it also affords the opportunity for the parent to offer greater time and attention to the baby during its first years, which is most important to their development. So we want to counsel patients about birth control during their pregnancy. So from the moment they get pregnant, I'm like, so what are we going to do to prevent another baby right away? Because we want to let your body heal and give you time to bond with this baby. And that's when we talk about LARCS, or long-acting reversible contraceptives at this point. So next slide. We want to talk about the risks of back-to-back pregnancies with these women. The list of preconception care services comes from the CDC. It's important to note that conversations about preconception health should occur on an ongoing basis. So we want to talk to mom about the risks of having these back-to-back pregnancies, which is they can have an increased risk of uterine rupture with their next pregnancy, inflammation of the genital tract, stress on the immune system, anemia, and for the baby, next baby could be affected by low birth weight, increased risk for premature birth, undeveloped lungs. So we really want to counsel these women and help them decide when it's best for them and their body to have their next pregnancy. So next slide. We're going to move on to hormone contraception and women living with HIV. Next slide. Most hormonal contraception is safe and recommended for women living with HIV. Interactions between hormonal contraception and antiretroviral drugs that compromise hormonal contraception efficacy are possible. So for example, several NNRTIs and protease inhibitors may reduce the contraceptive efficacy and may increase adverse effects. However, it's unknown to what extent drug levels change and compromise the contraceptive effectiveness or increase adverse effects. So as providers, we need to check the clinical guidelines to see if there are any drug-drug interactions that have been identified between the treatment regimen and the desired hormonal contraception, and the guidelines are very clear and very easy to use. So if interactions are shown, then alternatives may be recommended for that patient. It's important to note that interaction concerns should not prevent hormonal contraception prescription when patient preferred. So we definitely want to counsel about all of their options and let them make the best decision. Next slide. So like I was talking about before, long-acting reversible contraception, or LARCS, are the best for patients. As with all patients, we want to continue to provide counseling, and this is the most effective method. So I always start my hormonal contraception talk with the benefits of LARCS and which different LARCS are available. But if a patient were to want, say, patches or rings or pills, we definitely want to counsel them on those, as it is the patient's body and the patient's choice. Next slide. So there's a recent analysis confirms that there's no increased HIV risk with oral contraception. There's limited data that indicates no increased risk with the use of levonorgestrel implants, and there's no data that's available on the etonogestrel implants. There's no data that exists on hormonal contraceptive rings, patches, and the IUD HIV risk. In conclusion, more research is sought. So the ECHO trial stands for Evidence for Contraceptive Options for HIV Outcomes, aims to examine whether Depo-Provera and another injectable called NET-N, as well as Jadel, which is an implant, and a copper IUD device, Paragard, results in a higher HIV risk. Women would be randomized to one of these arms to receive one of these long-acting reversible contraceptives. All of the options are hormonal except the copper or Paragard IUD. There's a debate on whether the trial should be conducted. Opponents contend that the resources to conduct the trial should be investigated at the country level to expand method mix and move away from Depo. But in conclusion, more research is needed on contraceptives and HIV. Next slide. So the bottom line on contraceptives is we want to educate our patients about the importance of contraception for pregnancy spacing and prevention. We want to make sure we talk them through what is known and unknown. We want to listen to their concerns and context and ultimately let them decide what option is best for them. And at this point, I'm going to turn it back over to Pamela.
Thank you so much, Maggie. I want to reiterate to everyone that you can send in those chat questions. Please get those typed in. I think we've only got one so far. So we really want you to be sure and send in those questions that you may have about today's webinar and the subject matter in general. And so again, let's get those questions in. So now, taking a look at resources, earlier we mentioned how important it is to not only support and initiate those conversations with patients and their partners, but to also have resources that are available to you as providers. Always keep in mind that you don't have to know the answers and how important it is for you to be able to call and reach out to someone to get expert support 24 hours a day. 7 days a week. And so we do have some information here. We've got the Clinician Consultation Center out of the University of California, San Francisco. And so we've got this web link here, but you can contact them at 888-448-8765. Here locally, we also have the Illinois Perinatal HIV Hotline, which is at www.hivpregnancyhotline.org/Illinois hotline. And also their number here is 800-439-4079. We do recognize that some folks may be calling into today's webinar from out of state. But again, we have national and local resources. But just know that there's a wonderful network across the country to service support for your efforts around providing high-quality clinical care for people living with HIV as they plan pregnancy and for their sexual reproductive health, for contraception, etc. So next slide, we have more national resources. We've got the provider checklist and questionnaire. We've got a preconception guide for women living with HIV and providers. And we're also going to provide you with a set of slides as well, just so that you know. Also, we have HIV out of San Francisco, which is a hub of positive and reproductive sexual health at HIVonline.org. We have more information about One Key Question at onekeyquestion.org, and also the National PrEP Locator for those of you that may not be familiar with your local PrEP resources and who your local PrEP providers are. Hopefully you're the PrEP provider, but if you are, we want to make sure that you get your information entered into that database so that folks can find you as well. Next, we have the MHPPPI Resources. We can be found at www.mhppi.org, mh3ps.org. We've got videos, state resources, clinical guidelines, brochures, postcards, training slides, and so we've got a wealth of information, and a lot of that of what you will find on our website will refer you and link you to other websites and a wealth of information across the country. And so I'd like to, at this point, share our acknowledgements. We've got a nice long list of individuals that we've worked with the duration of the MHPPPI project. And just to let you know, the MHPPPI project ends September 30th. And so you folks are participating in our sunset session, basically. And so we've been so happy to have you today. But, you know, without all these folks that we've got listed here, we really couldn't have done the wonderful things that we've done over the past couple of years in rolling out the MHPPPI curriculum and trainings. And so we want to give, today we want to give a special shout out to MATEC, the Midwest AIDS Training and Education Center, for co-hosting today's training and for also being an important liaison throughout the Midwest Great Lakes region. And so thank you, MATEC, and thank you to all of you that are MATEC followers. And so we've got, I believe, a question that, we've got a couple of questions that Sarah's going to share, and so I'm going to turn it over to Sarah.
Thank you. Again, thank you to Pamela and to Maggie for all this amazing information. I know it might be kind of marinating right now, but if there is something that you are thinking about, again, up the slide that we have is how you can submit your question. So please do that. And then really quickly, before I get to the questions, I actually got someone sent over a comment. They actually had to leave the webinar, but I just thought I'd bring it up as an example. They said that they were a case manager and that they were really happy to get this information. They hope to talk with some of their infectious disease medical providers to stop discouraging pregnancy among women living with HIV. And I think we all, no matter what role you have, case manager is just an example that we all have a part to play in kind of changing the paradigm, as Pamela talked about and Maggie talked about earlier on in the webinar. So that's just an example of someone who made a little comment, and I thought that was really helpful. So one question that we had come in is about disclosure. This is obviously, you could have a whole webinar on disclosure, but as we're talking about what are some tips or some strategies that we can counsel women on disclosure when they're pregnant? You know, there's a lot of heightened attention, I think, on women when they're pregnant, no matter what. If you're adding on top this issue of disclosure to either a partner or to family or their support system, what are some tips or strategies that we could counsel women on? And that's for Pamela or Maggie or both.
Maggie, you want to do that?
Sure. So, yes, it could be a whole webinar on disclosure. So there's different states have different rules. So I know I'm in Indiana, and in Indiana you have the duty to warn. So you only have to tell somebody if you're going to have sex with them, if you're going to share needles or paraphernalia with them, if you're going to donate blood, plasma, anything like that. So I always counsel patients the same on disclosure, where I want them to feel comfortable disclosing their status. And if they don't feel comfortable disclosing their status, then they shouldn't, I don't feel like they're ready to disclose their status. So you want to disclose it to family or friends who you feel close with, because if you tell the wrong person, then it might get into more ears of wrong people. So I always counsel patients that, sit down with your family. Don't just like casually mention it. That would be very awkward, I'm sure, for both parties. But having a loving and trusting relationship with somebody, I feel like, yes, it would be very hard to disclose something, and I can't relate to these people in any way. And I wish I could have, a magic way of being able to help with disclosure, but I think it's different for each person. But talking about pregnancy and disclosure, if they don't feel comfortable disclosing, they don't have to disclose to anybody but their sexual partner. It's very easy with everything going on in labor. A lot of times family members aren't going to come in and be like, oh, look, what are they hanging? AZT, what's that for? Usually patients, families are much more excited about the birth of baby than anything that's really going on beforehand. So talking about with the patients and saying their comfort level and why they feel like they need to tell that certain family member, and then counseling them on different ways to disclose that status. And sometimes I've had patients even come into the office and disclose with me because they know that that family member will have a ton of questions. And so they want to be able to provide those answers, or, going to a mental health counselor and disclosing it with them. So it's different for every patient. I wish I had the magic answer.
Those are all the great strategies though. So thank you, and for bringing up those kind of nuances. Is there anything else you wanted to add to that, Pamela, or that's good?
No, that's wonderful.
Okay. Another question that we had come in is about something that you covered earlier, Maggie, about different ways of preventing transmission of HIV. So this person asked, why would a couple use both treatment as prevention and PrEP when they're trying to conceive?
Sure. So that's a great question. So to me, that was brought up in a very funny way. Why use both? So let's talk about the opposite. So preventing pregnancy, why use both birth control and a condom? Is how I see it. So why use both? You're just being safer. So it's talking to the patient and the partner. So say the man was living with HIV and the female was not. I've had a lot of patients come in where in that scenario, and the man knows that he's virally suppressed, and so does his female partner, but he doesn't want to pass HIV to his partner or have a baby living with HIV, so they just take that extra step and they have the woman living with HIV be on PrEP, and it's just an extra safety step that some patients like to have. Pardon me.
Great. Anything you want to add, Pamela? Again, I just want to give you the opportunity.
No,
okay, no, because I know that Maggie's doing a great job covering it. We've had a couple things come in about breastfeeding. So I know there were several slides and several discussions on breastfeeding. So there's a couple of issues, and the first one is about we referenced the U.S. recommendation on breastfeeding with a suppressed viral load. We know that we're talking about, a lot of times when we talk about suppressed viral load, we're talking about sexual transmission, but this is now regarding breastfeeding. And the person is wondering, do you think that that's ever going to change? You know, in terms of if someone does have a suppressed viral load, do you think the recommendations would ever change that, oh, maybe they'd say, okay, you can go ahead and breastfeed?
Sure. So I think that's a very tricky subject. I would love to see those studies, but I don't know who we can find who would be interested in those studies, who would be able to do that, because you would have to think it would be having to be a woman living with HIV with a suppressed viral load, taking that chance of transmission as she's breastfeeding her infant. I recently had a patient who was from Africa with her first pregnancy. She lived in Africa, breastfed her baby. She was HIV positive, and baby doesn't have HIV. Well, now that she's been in the United States for a year and she's pregnant here, we're telling her not to breastfeed. And she had a really hard time with that. And she breastfed while in hospital. And so I think there were about 15 notes, written on her explaining the risks of breastfeeding. But I would absolutely love to see a study, as they do it in Africa all the time, where these women are suppressed. And I would love to see the amount, because I think it's very rare for a child to be exposed to HIV if they do have a suppressed viral load. But I think it would be really interesting to see the studies. I would look forward to seeing a study like that in the future, but as of right now, more research is definitely sought.
Yeah, definitely. I agree, because yes, I know as you alluded to, the recommendations are different here and in other countries and continents. And I know that the WHO guidelines differ from the US guidelines, and it's interesting because they are looking at the same data, but I think it's just about standards, and how and why we recommend certain things. So I do think it's also a case where more research is needed, and investment in that research is needed. So I too look forward to those studies, and hopefully some of those studies are getting funded and being worked on right now. So yeah, I know that and just to add to, I know that we covered this too, that and you mentioned this, that some people have a psychological connection and desire, or a cultural connection or desire to breastfeed. So it is important that we talk about the different ways that people can have that connection and closeness, even if they are bottle feeding. And I know you mentioned that earlier, Maggie, but that is a thing I think we need to pay attention to. It's a very deeply held belief for a lot of people. Switching gears a little bit now, there was a question that came in about transgender patients and sexual and reproductive health. It's kind of a broad topic. The person asked us, how do we engage transgender patients with all of this? So I don't know if you've had a patient, Maggie, come through that was transgender, or their partner was transgender, if there's anything that we'd want to highlight, or any kind of issues that bubble up that you might want to just talk about when it comes to if you were a transgender person comes into the office and wants to know more about their reproductive health options.
Sure. So I honestly cannot speak on that. They opened a transgender clinic at the hospital that I work for, which is absolutely fantastic. And they have taken over transgender care, primary care, reproductive care, hormonal care, and everything like that. So I only saw them for their antiretroviral medications, and I never had a transgender patient who was interested in conceiving. They were all interested in the opposite contraceptive services, which I was able to provide. So I can't speak on the other subject. I apologize.
Oh, no, that's no problem.
I mean, I feel like you should treat every patient just like we talk to men and females about their desires and needs. I mean, this is the same with our transgender patients about what they desire and what they need, and preconception and contraception counseling.
Agreed. Anything to add to that, Pamela?
No, actually, but I do want to reiterate how important it is that providers are basically practicing how they engage and communicate with patients, particularly patients that they may not be as comfortable engaging with. And so, you know, we talked earlier about why provider-initiated conversations matter, and those conversations are, you know, they include everyone. And so helping clinicians to be able to function out of their comfort zone, in the sense that any individual, no matter how they may present in a clinical setting, that provider needs to have a level of comfort in communicating with them and being able to broach conversation around pregnancy planning and desires. And so one of the things that we do in our full training is that we actually allow our clinicians to practice engaging in dialogue with, you know, a patient. And so the role playing is critical, and we feel that clinicians should want to do some role playing with their fellow providers. And we know that there's limited time, but we know that practice makes near perfect, right? So the more you practice, the better you get with any skill, and the better equipped you are to engage and provide quality conversations and care. And so we would say that, and I don't know, maybe Maggie, if you have, for example, trans men that are coming in for gynecological services or not, but we know that there's definitely a great need in getting materials and information out to trans men regarding gynecological care and services, and also, again, having these conversations around pregnancy planning, just like with talking with trans women. And so we're hoping that we will gradually move toward this being more commonplace and you know, building the comfort level of clinicians. And so we're really hoping that our clinical advocates are advocating for centers like the one that you just referred to, Maggie, which sounds phenomenal, and that other providers are actually going there and asking questions and learning and going to trainings and expanding their skill sets and knowledge, so that everyone feels free to go into their clinical settings and have those conversations, and that, again, that they're being initiated by the provider and not necessarily by the patient, again, which is a major difference. And so we're looking to see if we have any more questions. I think that, Sarah, do we see any more?
None has come in,
Okay.
and so I said I'll give people just a last few minutes to type them in while I just do some of our wrap-up housekeeping. I just want to thank, again, everyone for joining us today and learning all this information, kind of absorbing it, and I hope you are able to then go back and use these resources that we provided with NIPI and others. Again, thank you to Pamela and Maggie for the information. I think it's been really well received. Again, we are from the Midwest, HIV Prevention and Pregnancy Planning Initiative, or MHPPPI as we like to call it, and as Pamela said, it's mh3psnni.org. Also, our co-hosts and co-sponsors, the Midwest AIDS Training and Education Center. One last thing I wanted to say is there were, people at the outset were asking about the credit situation. So yes, will be available, so you can receive credits no matter where you live, no matter where you're tuning in from. The only thing is that we would need you to fill out the kind of post-webinar evaluation /survey, and that link will be coming to you from the system. They'll send you, you should be getting in your email right after this, and popping up on your screen a link. It's a SurveyMonkey link, so that's what to look for. And you fill that out, then we will note that on our end, and Pamela will be the one getting the certificate of credit to you. And then there are not any more questions, so I think we can go ahead and wrap it up. If you want to go, I think the last slide has also Maggie's contact information. So that's up there too if you ever need to, if you want to reach out, get in touch. And I'll just leave space for Pamela and Maggie to make any of their closing remarks.
Maggie, is there anything you'd like to share? I hope you're okay with folks contacting you, and I really do hope that you all will reach out to Maggie, clinician to clinician.
No, I really appreciate the opportunity to speak today, and I look forward to any questions that are sent my way. I check my email daily, so hopefully I will get back to you as soon as possible.
Awesome, and I just want to thank you, Maggie. You've been great. You've been actually quite stellar for not only our in-person trainings but our webinars, and we truly appreciate you and appreciate that you've been sharing your expertise with us. Again, we want to thank everyone for participating today. We've got Maggie's information here. Maggie is a women's health nurse practitioner at Eskenazi Health OB-GYN in Indianapolis. And we also have there our email address and telephone number for the MHPPPI project. So again, thanks everyone, and have a great day.